Hi everyone, I am Dr. Wafa Ibadawi, a senior consultant histopathologist and head of pathology department AKMICH KSA. I'll be talking about sex-cord stromal tumors of the ovary, microcystic stromal tumor. General background. Ovarian microcystic stromal tumor is a rare benign tumor within the category of pure stromal tumors. Patients are typically premenopausal, although age range is wide. They usually present with symptoms related to a pelvic mass, or it may be an incidental finding. Endocrine manifestations are rare. Molecular analysis shows somatic missense point mutations in exon 3 of CTNNB1 in approximately 50% of cases. They lack DISA1 or FOXL2 mutations. Gross appearance. The lesion is unilateral and usually less than 10 cm in maximum dimension, mean 9 cm. A magnetic resonance image MRI of the intrapelvic mass measuring 7 cm in diameter with a cystic cavity seen in this photo. The mass is relatively well circumscribed and lobulated. The cut surface of the tumor is firm and tan to white. Hemorrhagic areas and/or necrosis may be noted. A cystic mass with thick wall, light tan in color, and elastic hard inconsistency. See the arrows in this image. The inner surface, see asterisks, is somewhat hemorrhagic. Microscopic features of microcystic stromal tumor. Fibrous bands and fibrous plugs subdivide the tumor into lobulated solid cellular islands. A medium power view shows the characteristic microcystic pattern. Higher power view shows the typical microcystic pattern and tumor cells with bland nuclear features. The distinctive microcystic pattern is characterized by small, round to oval cystic spaces. Focally, the cystic spaces coalesce into larger irregular channels. The cells contain finely granular, faintly eosinophilic cytoplasm with generally bland, round to oval nuclei with fine chromatin and small indistinct nucleoli and 0 to 2 mitotic figures per 10 high power fields. This photo shows aggregates of signet ring-like cells. Foci of bizarre cells, like those in other sex-cord stromal tumors, are present in 60% of the tumors, like in these two photos. Intracytoplasmic vacuoles are frequently present. Some of the intracytoplasmic vacuoles could be calcified, giving rise to a samoma body-like appearance. Please keep in mind that features to establish a diagnosis of microcystic stromal tumor in well-sampled specimens include a microcystic pattern and regions with lobulated cellular masses with intervening hyalinized fibrous stroma. No morphologic features enabling any other specific diagnosis in the sixth chord stromal category. No epithelial elements, no teratomatous or other germ cell elements. Immunohistochemistry. Microcystic stromal tumor shows positivity for beta-catenin, diffuse strong nuclear and cytoplasmic immunoreactivity. Cyclin D1 strong and diffuse nuclear immunoreactivity. WT1 patchy nuclear immunoreactivity. CD10 diffuse and strong cytoplasmic immunoreactivity. Ki67, it shows low index. The tumor are typically negative for inhibin or calretinin. Differential diagnosis of microcystic stromal tumor. Sarcoma is the most common tumor in the differential diagnosis of microcystic stromal tumor because both often occur in patients of similar age. Both have a vague lobulated architecture with hyaline bands. Both may have bizarre nuclei. Sarcomas show often association with estrogenic manifestations. Strong positivity for inhibin and calretinin. Negativity for nuclear beta-catenin. Sarcomas lack the characteristic features of microcystic stromal tumors, including microcystic component, intracytoplasmic vacuoles, positivity for nuclear beta-catenin. Prognosis and therapy. Ovarian microcystic stromal tumors are benign with excellent prognosis. Conservative management with unilateral or oophorectomy is sufficient. These are the references. Thank you.